welcome everyone. Thank you all for joining. We have an exciting webinar this evening where we're going to explore the fundamental principles of neuromuscular electrical stimulation and reveal some insights from a recent randomized clinical trial highlighting the impact of Excite OSA therapy for mild OSA. My name is Jay Cranston, and I'm a marketing manager at Signifier Medical Technologies. I will be your host this evening, but the star of the show is Dr. Naresh Punjabi. So welcome, Dr. Punjabi, and thank you for joining us. Before we get started, I wanted to mention that there will be a 10 to 15 minute Q&A session at the end of this webinar, but feel free to ask your questions. There is a Q&A section within the Zoom webinar. So ask those questions as they come up throughout the webinar. We may answer some directly in the chat, or we will leave them for Dr. answer them at the end. So a little background about Dr. Punjabi. He's the professor of medicine and chief of the Division of Pulmonary, Critical Care, and Sleep Medicine at the University of Miami. He received his undergraduate education in biomedical engineering from Northwestern University and his MD from the University of Chicago. Completed his post-doctoral training in internal medicine, pulmonary, critical medicine, and sleep medicine, all at Johns Hopkins University School of Medicine. And his academic tenure has been marked by significant contributions on the epidemiology of sleep apnea, with a particular emphasis on outcomes including insulin resistance, type 2 diabetes mellitus, and cardiovascular disease. He's also been a co-investigator or a field site PI for multiple multi-center epidemiological studies and randomized clinical trials related to obstructive sleep apnea funded by the National Institutes of Health. So without further ado, I will pass it over to you, Dr. Punjabi. Thank you again.
Jay, thank you for that introduction. Welcome, everybody. It's a bit late on the East Coast, so hopefully I'll keep this short, to the point, and keep it informative. So what I'm about to present to you are results of a small study that we have completed on the use of NMES, neuromuscular electrical stimulation, for patients who have mild obstructive sleep apnea. As I'll show you, this is a device that is actually used during the daytime for approximately 20 minutes. And the fundamental basis, the physiological basis for this device is that it improves muscle tone in the tongue with this 20 minutes of exercise, if you want to call it that. What we embarked on about 2 years ago was to ask a very simple question. The first part of that question was, will patients use a device such as this? And then what is its impact on clinical outcomes? So I want to give you our general outline. I'll talk to you about what the overall objective of the trial has been. I want to describe the intervention and specifically also the development of a sham device. We were very motivated by this whole idea of neuromuscular electrical stimulation and felt that there was a need, particularly if this approach is to become widely used, we need more empirical data. In order to collect that empirical data, it was critical for us to think about what is the comparator. So we embarked on also developing a sham device alongside testing a couple of aspects of neuromuscular electrical stimulation with the Excite device. One of the challenges that we had is, how do you go about thinking about a study that is small, preliminary, but is powered enough to be a study that's informative? So it is a pilot. So it was a challenge to think about how we're going to figure out the number of people to enroll and what that would yield us. I want to show you how we screened and who we enrolled. We want to talk about the primary endpoints and our exploratory outcomes. I'll describe who we eventually ended up enrolling, and then present the results of what we found in our primary outcome and our exploratory outcomes, and end setting up the stage about what we've learned and where we need to go into the future. Now, all of this has been recently published, literally in the last 2 months, in the European Respiratory Journal of Open Research. So this is an article that you can literally grab without any need for journal subscriptions. So if you were to just even Google ERJ Open Research NMES, you'll find this article. So it's all published, I believe, literally in December or late November of 2023. So what is NMES? NMES is neuromuscular electrical stimulation, as the word states it. The principle here is fundamentally quite simple. The folks at Signifier have developed a device, and you see it in its frontal projection here, and you can see it as a cartoon where it's been sort of put in someone's mouth. The idea is that there are 4 electrodes here that are used to stimulate at a particular frequency for about 20 minutes. The user can actually change the intensity of stimulation. And the settings range from 1 to 15, as I will show you. With each incremental gain of the setting of this device, more amperage is delivered. And I will describe how 1 differs from 15 with regards to how much current is being applied. I have personally used this, and I find it interesting and relatively easy to use. So here's the paper that I was referring to. It's published in the ERJ Open Research. And again, you can either Google just the word NMES and sleep apnea in ERJ, you'll find this paper. So what was our objective? How did we embark on this? And what was the goal 2 years ago when we were all struggling with the burden of COVID? We wanted to test whether this device, which was relatively fresh on the market, whether people would use it. The recommended duration per the manufacturer is 6 weeks. So fundamentally, what you're supposed to do with these patients is that if they have mild apnea, which is its current indication, you give them this device, which they can use anywhere during the day for 20 minutes. There's a very sophisticated app that comes along with this device that's able to guide the individual and allow the individual to change the setting. So it's a 6-week intervention. Our first simple question is, will people use it? So we decided to look at adherence to therapy as a primary outcome. Now, most of you who take care of patients with sleep apnea know that adherence to CPAP has its challenges. So that made this outcome even more interesting. That if this device can be used or is used by patients, and if it is efficacious, then there is really a good chance that this becomes part of the armamentarium for treating people who have sleep apnea. So there were a multitude of reasons that motivated us to think about adherence as the primary outcome. And of course, we wanted to look at other things. We wanted to look at respiratory event index, the apnea index, and the hypopnea index. We also wanted to know whether any of these indices of sleep apnea severity would be different if you were in the supine position or in the prone position or on the side position. We also wanted to look to see if people felt less sleepy if they were to use this device and follow them for 6 weeks. And again, I've outlined why adherence. We know PAP adherence is a challenge. If we are able to identify a new approach to therapy, it better have better adherence than PAP. And before doing a very large study where we don't really know what the adherence is going to be like, would be very ineffective and very expensive. So adherence was important because we wanted to make sure people would use it, but at the same time, we wanted to also look at sham. If we developed a sham device for this approach, will people use it as much as active therapy? So if that were to be true, then we would have a sham device that we can test in larger studies in a wide variety of patient populations that perhaps are not restricted just to mild disease. So there were a number of reasons why we felt adherence should be the first topic alongside with developing a sham device. One of the challenges we had is, how does one go about even figuring out the study or the sample size? How does one approach this problem? So we said, okay, we think, and this was just a hypothesized estimate, we think that at least 85% would use this device as recommended 20 minutes a day for 6 weeks. We picked this number because it's a high number. And at the same time, if this number was to be the truth, we would have something that would be much more superior to CPAP, at least with adherence in mild patients. So we use that as a metric and anchor our sample size for the study around that focus of at least 85% would use this device as recommended. Now, in order to figure out sample size, we always have to have some sort of margin of error. Well, we can't nail it at 85%. What are we willing to tolerate? So we kind of picked somewhere between 10 to 15%. Among a group of individuals that were involved in this study, we debated, should it be 10%? Should it be 15%? If you use the 10% marks, the interval would go from 0.75 to 0.95. If you used 0.15, the interval would then go from 0.7 all the way to 1.0. So we decided to cut it in half roughly. Now it's okay to pick something that you think you can estimate. So we said, look, within plus or minus 10 to 12%, we think 85% will use it. Now, once you know those two estimates, once you know that you're going to do a study where your target is going to be about 85% of our patients use this, with a margin of error plus or minus 10, there are statistical approaches to determine what the sample size is going to be. And I've just described it here, where the margin of error is in the denominator, and this expected proportion of individuals is P, and you can use this formula to figure out how many people we need. So our estimated sample size for the study ended up being about 34 individuals, 17 per group, if we're going to randomize them half to sham, half to therapy, active therapy. Now, to build in a little bit of wiggle room, we said, okay, we'll do a little better than that. We're going to assume that we're going to have problems. Maybe 15% of our individuals don't use it, lost to follow-up. So we bumped up the sample size about 15% from 34 to 40. So that gave us the potential for 20 individuals per group, and that's how we started. We knew that we wanted to be focused. We wanted to make this a pilot study. And 20 individuals over the course of, per group, over a course of, let's say, 12 months, was a reasonable amount of sample that we could recruit. Now, kind of started describing what NMES is, but let's get into a little more detail about what that is. There are 4 stimulation electrodes. 2 are located above and 2 below the tongue. What the stimulation is, it's a series of pulses with rest periods in between. The active therapy approach with the Excite device has a range, as I've mentioned, from 0 to 15. And that range from 0 to 15 can deliver voltages from 2.2 volts all the way to 32 volts. The recommendation is that you start low. And as you go on, perhaps within a session or across sessions, you can keep incrementally increasing the voltage to what the patient can tolerate. The sham device is something we had to build. In order to be a real sham device, we wanted to make sure that the setting that was possible on the app was from 0 to 15. The device is exactly the same, looks the same, manufactured, same everything, same app. Delivers 0 to 15, but these sham devices, when you go from 0 to 15, these were adjusted so that the voltage was from 0.4 to 6. Now we picked that roughly to be 1/5 of what active therapy is. Now we had assumed at that point that 1/5 of what the voltage should be will probably not be therapeutic. It was a hypothesized guess. We didn't have evidence for this. So we took some risk as to say, well, 6 volts of stimulation is probably not going to do much. So it's 1/5 of the maximum delivered by the active therapy. Now, when you look at what the device settings are, that's on this x-axis here, and the voltage delivered, it is a linear relationship. So it jumps 2.2, 4.4, 6.6, et cetera, et cetera. It keeps jumping in those increments of 2.2 volts. For the active arm, which is in blue, the sham arm, shown in orange, is a very blunted curve, still linear, but incrementing by only 0.4 to 0.5 volts. Very small jumps, with the maximum again being 1/6 of what the active arm would deliver. So in order to get this trial started, we decided to recruit from our own center in Miami. So we are a tertiary multidisciplinary sleep center. We wanted to make sure that we include people with mild OSA, which is its current indication. Now, in order to have mild OSA, we said we would take results of a full night in-lab sleep study or a sleep apnea test. However, to be in this study, you had to go through testing again. So we would do multi-night testing. We decided to retest everybody that would qualify. And they would have to show mild apnea again on these 3 nights. We recognized that we could not get 3 nights on everybody. So we decided to take 2 nights, or at least the minimum requirement. And for these 2 nights, the median, the middle, had to be between 5 to 14.9 events per hour, meeting the current criteria for mild sleep apnea. These home sleep apnea tests were scored using the 3% desaturation criteria. So we used the Knox device, and as I just mentioned, we used 3% to define a hypopnea. Apneas were, of course, not related to desaturations and were scored as recommended, which is a 10-second pause or more. Now, what were we interested in as far as the outcomes for the study? Well, we wanted to know how many people at 6 weeks, 42 days, would use the therapy. We had assumed that at least 85% would. Then again, as I mentioned previously, our other outcomes were, does this therapy change the respiratory event index, or the REI? And of course, we want to look at this in different positions, the overall REI, supine, and non-supine REI. We were also interested in apnea frequency and hypopnea frequencies, and again, by overall and position-dependent indices, and finally, looking at the Upward Sleepiness Score. So those were our exploratory outcomes, because we really didn't power the study to see if we could find a difference in the REI or AI or HI or the ESS. Now, to analyze these data, we had information at baseline, 3 or at least minimum 2 sleep studies, and then we have the same thing at the end. We were concerned that there would be differences between groups for things like age, sex, body mass index, and supine position. So we decided that we wanted to make sure that both groups, when examined for outcomes, were comparable. Here's what we ended up doing. 78 patients were noted to have mild sleep apnea. Now, of those that were referred for the study, we actually were eventually randomizing 40. 40 patients with a median REI of 5 to 15 events per hour were actually enrolled. Now, the others were excluded because about 38, because 20 were not interested. 13 did not meet the criteria because the REI overall was over 15, and the rest had an REI less than 5. So 40 were randomized. Of those 40, 21 were randomized to active therapy, active NMES, and then the other 19 were randomized to the sham arm. We had follow-up data on all of them, 21 in the active arm and 19 in the sham arm. So all in all, it was what we expected, roughly 20 per arm. We ended up getting the full sample size. We were able to randomize without any loss to follow-up during the period of the study. Now, who did we end up including? Here's the table of all the demographic information. Let's go through this sort of line by line. The age was on average around 50 in both groups. These were not statistically significant. The sham group was a little older, 54, but again, there was no significance between these two, between the ages of the 2 arms. They were roughly an equal number of men and women, 11 men in the active arm and 12 in the sham arm. Race distribution was also comparable, with 19 out of our 21 being white. We are in a Latino-centric population, so 13 of our 21 in this group and 11 out of 19 in our sham group were Hispanic. Body mass index on average was in the overweight range. These were obviously individuals with mild sleep apnea to start with, based on the baseline polysomnogram. So the BMI was 28.4, and the other one was 28.9. So there was really no difference between the two groups. BMI categories were comparable. We had a rough distribution of individuals who are lean, overweight, and obese, and again, comparable in both arms. The respiratory event index, the criteria that led us to be in the study itself, was also very comparable. The overall index in the active arm was 12.8 versus 12.2 in the two arms, and again, not statistically significant. And finally, the Epworth Sleepiness scores, while they are different, at least in magnitude here, of 8.2 versus 10.3, there was really no difference statistically between these two groups in any of the characteristics that you see. So at the end, we ended up recruiting a balanced group of individuals that were matched roughly on age, sex, racial distribution, body mass index, of course, respiratory event index, and the Epworth Sleepiness scale. So I've gone through all of these metrics with you. Now let's turn to the adherence and what we learned. The major, again, primary endpoint was adherence. Let's go through the adherence. And again, what you see here is active in the left column and sham on the right column, as we've done before. So the days used was our primary outcome. Remember, the total number of maximum days that are expected is 42. So in the active arm, the average used was 38.4 days, and then the sham arm was 38 days. So in both arms, it was comparable. The duration of use per day, which is recommended at 20, was again spot on for both groups. Most people used it as recommended, 20 minutes. The percent of days used, we broke it down into subsets. We wanted to understand who were perfectly compliant, who were close, etc. So a majority, more than about 2/3, were compliant as they should be at 100%. The groups, there were individuals that didn't use it perfectly. And if you just look at 70% or more, which is the top 4 rows, approximately 91% of individuals in the active arm, and about 90% of individuals in the sham arm used it to the same degree. All in all, adherence was great and comparable. So there's many things in order to take away from this. Only 2 out of our 21 did not use the therapy more than 70% of the recommended level. Why do we pick 70? That's roughly the criteria we use for CPAP as far as Medicare is concerned, fulfilling their criteria. So we use the same thing. So about 10% will not meet that threshold, at least for this. So if you look at adherence from a 70% or more, it'll be 90% of individuals will use this. Now, what's really interesting is stimulation intensity. Remember, this is based on a setting that goes from 0 to 15. The active arm, on average, had their settings around 9.8. Now, the sham arm is much higher, 13.4, which makes sense. Remember, the sham arm is not sensing anything. The voltages are low, so they're expecting to be stimulated more, so they crank it up. So this is a very nice observation that there's some awareness that the patients are feeling that they're cranking up. They didn't go all the way to 15, some of them did. So this suggests that the sham is working from the standpoint, at least the individual using it is not sensing the intensity, and they're gonna sense some of it, but not to the degree that the active arm is sensing. Now, switching from adherence to respiratory event index. We were not powered to do this. So let me show you the 2 groups. The sham group is on the left, where the purple box plot shows the usage, shows the distribution of the respiratory event index before at baseline and 6 weeks after. Literally no change in any of these things in the sham group. But when you look at the active group, you see that there is a drop in the REI from roughly 12.8, that was our approximate mean down to 9.3. So there is a significant drop. It's about 33% if you were to look at the relative scale. So while we were not expecting any improvements, nor did we power the study to show improvements in the respiratory event index, we found that patients with mild apnea, again, keep in mind, the upper end of the cut point was 15 events per hour. Patients with mild apnea do in fact improve, and the degree of improvement is about 33% with 6 weeks of therapy, 20 minutes during the day, which can be done anytime during the day itself. We were very curious about what happens if you look at supine versus non-supine REI. Again, in the sham arm, left side here, we saw that there was absolutely no difference in the distribution of REI baseline compared to 6 weeks. When you look at supine REI in the in the active arm, baseline and 6 week data were very different. In fact, there was a significant drop in the REI. Supine REIs are generally higher than overall REIs, and therefore you see a larger distribution, a wider box plot. Nonetheless, we see that there was a drop in supine indices. What's interesting is non-supine, it didn't matter. Non-supine indices in these individuals, whether you think of the sham arm or the active arm, were very low to start with. Overall average median is around 5, and it remained that way, and there was no effect on the non-supine arm. So fundamentally, we're seeing a position-dependent effect. Now, clearly that makes a lot of sense. What this is telling us is that in the non-supine position, where the airway is not as susceptible compared to the supine position, first and foremost, the disease severity is very mild, and there's not much of an effect. But in a susceptible position, the supine position, REI drops, and again, drops substantially by about 33%. Here are the data with regards to all of these indices, but in much more detail so you can see them. I'll go through them individually with you. On the left side is the active data. On the right side is the sham data. And again, what we've shown you is the baseline, 6 weeks, and the change between the two, and a p-value associated with that change. And we've done the same thing on the right side with the sham arm. So let's start first with the overall REI. I showed you in previous figures that the change overall was about 3 events per hour. And that is approximately 33% of the baseline severity of disease. The supine dropped substantially, 5 events per hour. And the non-supine, although it did drop and was significant, it was not as much. So what you're seeing is that you're seeing a change. The change seems to be much more significant in the supine position. When you look at the apnea index, there was really no change, but keep in mind, the amount of apnea we had in this relatively modest population was low. We had 2 events per hour for the apneas, and at 6 weeks, it dropped. In the sham arm, it was 2, it went to 1.8. So even though it was mild, we saw some decrease, and it was statistically significant, but again, 0.7 events per hour. Keeping in mind that the starting point was also very low. The supine index did drop also, as one would expect, but it was not statistically significant. So I think we really need all of the data. The overall seems to be dropping. I think this is just an issue of sample size and variability and noise in the signal than anything consistent. When we look at hypopneas, the overall hypopnea index improved by 2.7. Supine was also down, and non-supine also increased. Now the sham, all on the right side, absolutely had no statistically significant differences, except for this one aberrant 0.02 that you see on the right side, which is related to the sham non-supine apnea index comparing baseline to 6 weeks. And again, these are low numbers, small sample size. We have to be careful about not overreaching our inferences or making too many conclusions about apnea indices, particularly if they're so low and the change that they have. Now, what about the Epworth Sleepiness Scale? This is very important because it's one thing to say, well, the apnea index or the hypopnea index or the overall index decreased by X amount. The question is, what is its relevance? We found, and again, we were quite surprised at this, that the Epworth Sleepiness Score drops by about 1.8 points in the active arm. In the sham arm, there was no change. So the difference of differences was in fact statistically significant, and this was not something that we expected, nor was the study powered for either the respiratory event indices, nor was it powered for Epworth Sleepiness Scale. So it's interesting that active NMES patients after 6 weeks do notice a difference, keeping in mind that they were mild to start with. If you recall, the baseline Epworth Sleepiness Score in these individuals in the active arm was 8.3. So despite being in that very normal range, there was still a drop. The sham arm was about 10 point something, and the drop is insignificant. So what can we walk away with some of these very preliminary data on looking at active NMES versus sham? First, we found individuals tolerated well. There were literally no side effects. Initially, there could be some excess salivation for the first run or two, but short of that, there's really no adverse side effects of this therapy. Adherence depends on how you define it, and if you use the 70% threshold, 90% in the active arm and also 90% in the sham arm used it. So that sends a very clear message. A, it worked from the standpoint of people using it, but B, we also have a sham device that people use it as equally. Had people not used the sham as equally, we would be in trouble, because then we would not have the ideal sham device for future studies. Let's say if we want to move into the moderate group, even severe group, now we have something that we can give to patients where they can sense some voltage and still use it, and their adherence is comparable. Of course, all of these findings are preliminary because we have a limited sample size, about 40 people. But this is the first randomized clinical trial on the effects of neuromuscular electrical stimulation in mild sleep apnea. And I want to emphasize that this is really sort of a select group of individuals consistent with the current FDA indication of this device, which is mild sleep apnea. As I mentioned, the improvement in REI was about 30%. We noticed that the supine REI changed a lot more than non-supine. Again, it makes sense because in the supine state, you're more susceptible, and perhaps establishing an airway tone or improving it with this electrical stimulation over time has a bigger impact. To our surprise, again, we were not expecting this. Sleepiness scores also improved. Now, there are many limitations. Some of them I've sort of said as we've gone along. It's a small sample size. But despite its relative modest size, we think that we have learned quite a bit on not just adherence, not just the development of a sham device, but also that it may have some efficacy. It was single center, so there's problems of generalizability. Perhaps our data don't necessarily project to every day, the population at large with mild sleep apnea. We would like to see what happens when you go 6 months out, 12 months out. We didn't have long-term data. This trial was strictly limited to the indicated approach of 6 weeks of therapy. Now, we would love to see, does it work better in older individuals or younger individuals? Does it vary between men and women? Is the efficacy or adherence, for that matter, different? What about overweight or underweight or normal weight individuals? And again, are there race-related differences in treatment effects with this device? And I'm sure there are many other variables, particularly disease severity. I think most of us would like to know, does this work in moderate individuals, perhaps? And confirm that, in fact, if we look at a larger size, does it work in mild individuals, and are the findings stable over time? As I mentioned, it would be great to think about individuals with moderate and even perhaps severe sleep apnea if they're intolerant to therapy. Given the relatively safe nature of this approach with minimal to no side effects, I think we have a lot of potential on where we can go next. We are working on designing a study that will address some of these issues. I think what we really need is a study that thinks about milds again, but also moderates, but addresses some of the issues that you see here. Is what is the effects across age, sex, BMI, race groups? What happens with regards to fidelity over time in 6 months? Does the effect persist? How if we go about 12 months? So is 6 weeks of therapy necessary, or do we need to keep continuing the therapy at some level over the course of the time? And in fact, the current manufacturer recommendations are that there has to be some augmentation over time. A lot of questions remain unanswered about long-term data that we will hopefully embark on in the next 3 to 5 months and have some answers shortly. Again, this is where we're headed. We want to really think about a large sample size where we can answer some tough questions. I do think we need to start thinking about moderate individuals, and we need to not just exclude mild. I think we need to restudy this in much more detail. I think this intolerant to PAP group would be something very important for our field, to give them an option beyond things like oral appliance. And maybe even we can use this as an adjunct. Who knows? If we actually are able to perhaps change up airway muscle tone during sleep, maybe we could decrease the pressure settings on some of our patients that are on excessive settings or unable to tolerate it. So I want to end by saying that, yes, we have a new approach on the horizon. It seems to be very promising. The data from previous studies which were uncontrolled on this topic, and now this is the first controlled study with a control population and a single sham device, are extremely promising. And I think that motivates us to think about the next step and take on some of the challenges that we did not want to take earlier on. Taking in a large study, of course, has cost, challenges. We've learned a lot of lessons by doing this study. I think those lessons can now be implanted to thinking about the near future of what this device or this approach can do for us. So thank you, everyone. Jay, I'm open to questions.
Awesome. Thank you so much, Dr. Punjabi. Yeah, I think it's really exciting to see all of this data because it is Signifier's first RCT using a sham device. So seeing that, it helps to reinforce previous study outcomes and demonstrate the consistency in the efficacy of using NMES for OSA treatment. And to your point, it's a step to building bigger RCTs to help build consensus towards establishing Excite OSA as this low risk, low burden, and patient-friendly OSA treatment. So thank you so much for everything you've done. And yeah, this was a really great presentation. I'm glad people were able to join. And we do have some questions rolling through, so I will get started with those. Did REI include arousals? Did you gather arousal index data?
Yeah, so great question. The REI did not include arousals. We used primarily oximetry to drive our scoring. I think it's a fundamentally important question, which is, does the arousal frequency improve? In our next step, we are in fact going to tackle this issue because, of course, the burden of collecting EEG data, particularly in the field, in the home, with multiple nights poses a challenge. But I think we're not ready to take that challenge. We want to see, does the arousal frequency improve? So I think it's a great question, of course. My speculation is that if apnea is improving, most likely the arousal index I would expect to improve. So no, we don't have the data. We want to collect it, and that's our next step.
Great, thank you. Is there any MCID for apnea index, hypopnea index, and AHI? Can you comment if the device exceeded MCID for any of the parameters studied?
Yeah, what a great question, and very detailed one indeed, and I appreciate it, of course, for that reason. No, I am not aware of any sort of threshold MCID for any of these indices, apnea, hypopneas, or the overall REI-AHI. We know that the surgeons do this when they operate. They say, well, if we had a 50% reduction in your AHI, they consider that a success. That is the only thing I'm aware of, at least from the standpoint of decrease. Now, ideally, one could say, well, you need to get it below 5. If you really want to be puristic about this, if we find a treatment that is potentially curative, well, it should be below 5. I think that's hard. Clearly, all of you appreciate that there is going to be some degree of apnea that may be residual in these individuals. So I think, we don't know what these are. My hope is that we drop it by at least 35%. If a device or therapy, whether it's a device itself or pharmacotherapy, I think we need to have at least a third of a drop in its baseline value. Again, that's really arbitrary in my own mind. The surgeons use 50%. I think that's also arbitrary. Now, the unique thing about this Excite device is that because it's non-invasive, because it's used during the daytime, the burden is so low that I think most of us would accept a 33, 35% drop and saying, you know what, for the amount of effort, the amount of what the patient has to do, and in the daytime, remember, only 20 minutes in the daytime, this is worth that effort, even dropping it. We may convert some of our moderates into miles, and I think that would be perfectly acceptable for many of us. Snoring gets better. By the way, one thing I did not mention is that snoring episodes per hour in this study did in fact improve. So we know that the trend is all in the right direction. Now, where we draw that line saying, gosh, 35% is good enough for us to sort of think about this device and put it in the armamentarium of sleep medicine, we'll have to sort of wait and see when we have a larger sample size. We redo this and reproduce this stuff. So I think I am not at this point drawing a line in the sand saying, it's got to drop by this much. This seems very promising. It doesn't meet that 50% threshold surgeons use for their operative work on sleep apnea, but I think because of the non-invasive simplicity, I'll take a 30% drop in the ARIA. I think most of us would.
Great. Thank you. And you answered one of the other questions. Well, the question was, did snoring go away? So you said there were improvements in snoring.
We actually objectively looked at snoring. We looked at snoring episodes per hour. So the neat thing about snoring is that, and particularly a quantitative approach to snoring based on these home sleep studies, is that we can quantify the snoring episodes, or at least the computer can. And that's the neat part about it, is that apneas and hypopneas have some variability in scoring, but in scoring events. But snoring, which was quantified using an algorithm that comes with the software, dropped. So I think what's interesting is that all the things that interest us from a patient perspective, snoring, disordered breathing events, and sleepiness, seem to be pointing in the right direction. Magnitude that will most likely be of relevance to us given the simplicity of this device, and the fact now we have a sham device that we can really robustly test it in larger studies.
Great, thank you. So we've got a couple similar questions. So the one question is, does NMES during wake lead to tongue protrusion during sleep? And then with that question, it seems there's a little bit of confusion about the mechanisms of NMES and exactly what it does to the upper airway. So I don't know if there's a possibility of you going back to the slide to show the device and maybe talk about the mechanism.
Yeah. So I was reading that question also, and it does not lead to tongue protrusion. Let me go back to this device here that I had on the slide, because I think it is worthwhile to look at. The device is literally has a shape of a sort of a C, and it sits on the tongue. It's not like the hypoglossal stimulator, which is stimulating the nerve, and therefore the nerve is then going to activate the muscle. What this is really doing is stimulating the muscle directly. And that's why you see this in this cartoon, that it's sitting on the tongue, literally, 2 above and 2 below, and stimulating. I'll use a metaphor because I think some of us, or most of us, probably have done this. 9-volt battery to the tongue. Remember, feel that tiny little buzz? It's a little kind of a electrical feel. That's what that feels like. It doesn't even cause fasciculation. It's a stimulation of a muscle at a frequency where you don't see movement, You don't see protrusion. You just feel that there is a vibration almost, if I can use that word. You don't have a mechanical movement at all, but you feel, if I can use the word buzz, on the tongue itself. Again, there's no motion at all that is discernible, or you can even feel it. So I think there is no comparability to hypoglossal nerve stimulator. So that's the first point. The question about mechanism of action, we don't know is the bottom line answer. However, the field of neuromuscular electrical stimulation dates back almost 70 years. Neuromuscular electrical stimulation has been used to improve muscle tone, muscle function, strength by athletes, by people with spinal cord injury. That's perhaps where it's probably used the most. And the fundamental hypothesized approach is that if you improve endurance of the muscle, the airway becomes less collapsible during sleep. There are variants of neuromuscular electrical stimulation. This is a neuromuscular electrical stimulation of the tongue. There are suits that are made and are used for exercise that actually stimulate different muscle groups during exercise to actually increase the workload and improve the ability for that muscle to improve its endurance. So while we don't fundamentally understand, so for example, what the histological changes are, what the physiological changes are, it seems to be based on somehow improving endurance. There has been one study that looked at critical closing pressure, for example, with this. It was a very small study. What they found is that no, the critical closing pressure did not change, but what did change was the idea of tongue strength. So again, we're very early on in understanding the actual physiology of what this is doing. I think we've got a long ways to go on that also. But some of the preliminary work suggests that there may be some endurance-related benefits with this Excite device.
Perfect. Thank you. And yeah, we'll send some follow-up resources so you can also check out the website and learn more about Excite after this webinar. But it does look like we've still got some more questions rolling through, so we'll keep them coming. Have you used the device in moderate OSA off-label in your practice?
Yeah, the answer is yes, it is off-label. It's not then, of course, going to be covered by insurance. I have, and there are a handful of individuals that experience benefit from this, which is kind of related to another question that was asked in the chat, which is the response to therapy homogeneous, or are there individuals who respond to therapy more robustly than others? I think that's very critical. It's a question that we want to know. Unfortunately, we could not answer that. We looked, but we could not tell whether age was a determinant, BMI, race, sex. These demographic variables were quite interesting to us to see if there was better in one group versus the other. But given the limited sample size, I think what we noticed was there was just insufficient power to do those treatment of heterogeneity effects. That's what that question is asking is, was there heterogeneity? The answer is we don't know. And that's why we are embarking on a study of about 300 to 400 individuals so that we can understand which subgroup does it really work well in. One thing we can tell you now for sure, supine sleep apnea, yeah, the supine indices clearly get better. So that's sort of the first taste of heterogeneity of treatment effects, that there is a subset that will get better.
Great. Was response to therapy typically homogeneous, or were there individuals who responded to therapy more robustly than others?
I just answered that because I said, we don't know because the sample size is small. But I think there's going to be heterogeneity. There has to be. The concept of supine versus non-supine really sort of speaks to that. There are going to be people that are going to respond to this, and then there are going to be people not. My hypothesis is that the really overweight, obese individuals probably not will respond to this, as well as those that are perhaps leaner or not as much overweight or obese. So I think you'll see a BMI effect. Whether there's a gender effect, I don't know. Whether there's an age effect, I don't know. But it needs to be studied.
Okay. Must it be used long-term? Any change in phonation speech?
Yeah, so let me start with the second part to that. We are not aware, nor has it ever been reported, that there's any changes in phonation or speech. Again, I've used it personally, and I've noticed that there's really nothing really happens. Again, the only side effect that I saw was in the first 1 or 2 sessions, a little excess salivation because you're not used to having a foreign device sit in your mouth for about 20 minutes during the day. With regards to long term, again, that is really a question of interest. Where do we go trajectory wise? What is the frequency that is necessary for repeating? Once you finish your daily at 6 weeks, can you stop, or is there a need for sort of a booster effect? Maybe you don't need it as much. Maybe you need it for every other day, or maybe a few days a week at the most to keep that effect sustained. We just don't know. And again, a topic for us that we're going to embark on in the next study with our 300 plus cohort.
Okay, thank you. Has anyone done drug-induced sleep endoscopy before and after a 6-week training period to quantify collapse?
Yeah, we haven't, and I think that's important. As I mentioned earlier, there's one study by the UCSD group that has looked at critical closing pressure, which is directly related to the question they were asking about collapsibility. They did not find critical closing pressure all differences. But again, we have to be careful. There was a very small sample size. But even in that, they noted tongue endurance was better. So stay tuned on the mechanisms of action because we need to understand those. And I think over the next 12 to 24 months, we're going to get into some of these issues. I'm particularly interested in, are there histological changes? If you look at other NMES areas, and if you biopsy those muscles, you actually see a difference in the type of fiber. There is a transition between the two types, type 1 and type 2 twitch fibers. And that makes sense. And that has been also reported in the literature in other muscle groups where NMES is used. You also see a decrease in fat deposition in some of these muscles. We know nothing about the tongue. No one's ever sort of biopsied the tongue. It's an interest of ours. We're hoping to do some of this work to look at histological and maybe even morphological with MR scanning to look at, is there a structural change? And again, physiologically, there's that one paper from UCSD looking at tongue endurance and critical closing pressure.
Great. And I'm just gonna ask one more question. It looks like there was a question about clinical significance. So in your expert opinion, is 33% change clinically significant?
Well, we kind of talked about this before. The really sort of negative way to look at this, well, the REI just dropped by 3.3. Well, that's such a small thing. Yeah, that's true. But remember, we're starting very low. We're starting at a mean of 12, okay? The other thing is, how do you define clinical significance? If you contextualize clinical significance based on symptom scores, and if you believe in the Epworth, that drop, and the drop in that Epworth score is in individuals that were not sleeping to start with, number one. Number two, the magnitude of difference is comparable to other studies that use oral appliance for CPAP. So we have to be careful here, right? We have to be careful here about saying, well, what is the clinical significance? Is it the REI just dropping by 3.3 or 30%? Maybe not a big change, maybe a big change to some, but what's important is to contextualize in the sleepiness. So I would say yes, from the standpoint of clinical significance, not because the REI magnitude of 30% or that 3.3, but rather the fact that the Epworth sleepiness scores dropped, but there was a big drop in the active arm and not the sham arm.
Okay, great. Thank you. A lot of great questions came through, and it looks like we've run through them all. So thank you so much, everyone, for joining, and thank you, Dr. Punjabi, for your excellent presentation. It's exciting data that we have to share, and I know there's more to come. So we hope all of you join our future webinars, and you will all receive a follow-up recording of the webinar. So Dr. Punjabi, if you have any last comments.
I think we've discussed them all. I think this is an interesting approach. I think it'll hopefully become part of our armamentarium, but we've got some ways to go. And I think in the next 12 months, I think we as a field hopefully will add something that will expand, not just to mild. My hope is to look at this device in moderates And any change that may have some improvements, those that are intolerant, I think would be very helpful. Thank you everyone for attending.
Good night.